Hello, welcome again. Dr. Anthony Gonzalez here from Miami Community Health. Another important health topic. Today, we're going to talk about babies. We're going to talk about children. We're going to talk about kids. And we're going to specifically talk about surgery on kids. Have you had a child, a grandchild, somebody in your family that you know, maybe yourself, you've even had surgery as a child. So I brought with me first a friend and, of course, a colleague, a pediatric surgeon. We brought Dr. Eduardo Perez with us. Welcome, Eddie.
Thank you for having me.
All righty. So what does a pediatric surgeon do, and what are the areas that a pediatric surgeon works on?
Well, a pediatric surgeon is the true general surgeon, old school general surgeon. We work from, thorax, abdomen. We do any specialty, oncology, trauma, but we do it up to 18 or 21 years old. 50 years ago, we used to do all procedures, either cardiac. There's been some subspecialization, but we stick to cancer, minimal invasive surgery, anything you can think of, but specifically thorax and abdomen is pretty big.
Wow. And you guys are now diagnosing, or at least we are diagnosing now, some of these conditions that babies have even before they're born. Is that right?
Yes. Now ultrasounds are done much better. The resolution is incredible. And you can diagnose thoracic lesions, abdominal lesions, and you can get prepared for the delivery. And we actually talk to the parents in advance to tell them what's going to happen.
Wow. And so you guys operating on some of these babies like right after birth, like a newborn or a premature babies, you guys are operating on them as well?
And actually there's some operations that are done in utero. So that's how technology has gone. But yeah, you get prepared, or for example, you can have gastroschisis or omphalocele, which are abdominal wall defects where the intestines are born outside. Now the family can be prepared and we can fix it, but at least you go to a center that you can deliver and be ready for the baby.
Wow. Yeah. Not every place has pediatric surgeons available, qualified pediatric surgeons. I know from training, because, in our training, pediatric surgical training is limited, and the number of programs and so forth. So it's obviously important that when a mother knows that they have a problem, to be at a center where they have that facility, right?
Yes. Perfect example is diaphragmatic hernias. Sometimes the babies have to go on what we call ECMO, which is a bypass. Basically, you want to have that baby in a center that is ready for it, because you won't be able to transfer the baby in the case you need it, or it's harder. So that's the beauty of knowing in advance if there's, and again, these are small numbers. I don't want everybody to get scared. This is pretty small numbers. We're talking about 1 in 5,000, but at least you're ready for it.
Right. All right. So we're going to talk about a couple conditions that happen to babies and kids. I thought it'd be good to inform our health community and inform our community as a whole. What are some of the common things that babies or kids or young adults or teenagers have to deal with? And so that's what I want to talk about. So first thing we want to talk about is atresia. And explain to our public and our viewers, what is atresia?
Atresia is basically, if you think of the intestines as a tube, is a disconnection of the tube. I mean, it can be different things. You can have, we divide it in types, from just a little membrane to a total disconnection. You can have atresias in the intestine or in the airway, but that's what it means. So you can have, starting in the esophagus, esophageal atresia. So baby has an esophagus that is disconnected and we have to reconnect it. And then going down the duodenum, the small bowel, the colon, up to what we call an imperforate anus, which is a baby that's born without butt, and we reconstruct. You had to reconstruct it. So that's what atresias are.
So let's break this down. So I remember from my days in the 90s, in my rotations of pediatric surgery, esophageal atresia is where you have the esophagus tube, but it's not connected to the stomach. So the baby can't drink and can't even aliment themselves. So what do you guys, are you operating on these little babies?
Yeah. So there's different types. Sometimes the most common type is having a disconnection of the esophagus, and then your distal part is connected to the airway. So,
wow.
So it's actually impressive when you look at an X-ray. The way you find out is that you try to pass a tube and doesn't go through, but the X-ray looks normal because the baby's, all the air that he's breathing is going into the lungs and the intestine. So the operation is to basically control that, disconnect the distal part of the bowel from the airway and then connect it. And nowadays we can actually do it minimally invasive with, thoracoscopically with little instruments. I think the smallest I've done is 1.6 kilos. Imagine like a small premature baby,
3-pound baby,
3-pound baby, and you can get them connected. It's a beautiful operation. And once you fix them, I mean, there's stuff like could happen, areas of narrowing that we can dilate, but now we can get these kids done with basically scarlets with a little keyhole operation.
Wow. Okay.
Yeah.
So then you talked about the esophageal atresia, and then you also mentioned to me that there's duodenal and intestinal atresia. The duodenum, for our viewers, is the first part of the small intestine, right after the stomach, and the intestines, of course, the intestinal atresia. So those as well, you would operate them when they're young as well?
Yeah, those are actually more common than the esophageal atresia. It's probably the most common atresia we see. And it can be different things. It can be a true disconnection or something called an annular pancreas, where your pancreas is at the level of the duodenum, and sometimes it grows around it. And then you have to do a bypass. What you do is you create a connection between the proximal duodenum and the distal. You're usually doing
just creating
like
another you're creating a detour.
A detour.
Around.
And again, we used to do it, open, and now in some centers we can do it laparoscopically, 2 incisions, and you do the connection. Baby starts eating, and you're basically, baby is normal for the rest of their life.
It must be really traumatizing for families to have a newborn baby, 3 pounds, 6 pounds, having to have surgery. I mean, it's traumatizing. I've had my kids have surgery, and I'm nervous when my kids are 6, 8. My kid had 6-year-old had a surgery, and I was nervous about it. Well, when your kid is newborn and 6 pounds, it must be really traumatizing.
Yeah,
huh?
I think, and I had to give a shout out to, it's not only the surgeon, it's the neonatologist, the anesthesiologist. We've gotten so much better at managing these babies. If you think about babies and prematurity, we're talking about now survival is improving up to 22 weeks, 23 weeks.
Wow.
And those babies, the mortality is like, I mean, you can have a 26-weeker, and that's going to be, now there's kids in med school that were 26-weekers, and you're like, holy wow, and this is impressive. So it's not only the surgery part, it's just the whole neonatology field.
Complete team.
And the field has just improved in a way where, now I can operate on a 500-gram baby, and due to the good managed by the anesthesiologist and the NICU, these babies can survive.
Wow, great. All right, so we've talked so far about esophageal atresia, where the esophagus is blocked off. We talked about intestinal atresia. And the last one is imperforate anus. And I remember this. Imperforate anus is basically that the child has an anus that's blocked off. And that's important because as the child eats, it has to poop, and he can't poop. So is it that their anus is closed? They don't have an anus? Clarify what imperforate anus is.
So for imperforate, and it's different between males and females, but when you're being formed, the anus and the urinary system is together, and it's supposed to separate. If you don't separate, then you have a connection between the urinary system and the rectum. So it can be you're just on the skin and you have a perineal fistula. It can be a rectourethral fistula because you never made it. So the operation is to divide that fistula from the urinary system and create an anus where it was supposed to be. Wow. It's called a nanorectoplasty. It's a beautiful operation. Again, now we can do it depending on at what level the connection is. We can do it either laparoscopically or you do it all from the bottom. And then those babies you create, and that families, imagine you have a baby is born without an anus, and so you.
And is that something that, like, when they're born, the neonatologist or somebody notices that, because that's part of the exam of the baby that you check for the anus?
Yes, you'll be impressed. It depends. Sometimes if they have what we call a perineal fistula, so the anus is just a bit off. Sometimes those get missed, but sometimes you're born without it. And in fact, I mean, one of my partners just called me and said, you know what, there was a baby that was born. So I'm on call the weekend. I'm probably going to have to, if you're born without any perineal fistulas, then you need to, the first operation is to do a colostomy.
Okay.
So the baby can poop, grow, and then in a month from now, I'll go to the OR and do the operation depending. I have to see what level that fistula is. But they're basically, they never separated, or they never made it all the way to the right position. So there's different degrees. Obviously, the lower down you are, the better the outcomes. But again, we have ways to manage them, and they are normal kids.
Well, so we've talked about really the first condition that happens to, like, let's say newborns, neonates, and things like that. We've talked about these atresias, which are, the lack of formation or connection of the intestinal tract. And obviously some of these are picked up. Are they picked up before they're even born sometimes?
Yeah, I mean, I would think thoracic lesions is one of them. You can pick either if they have some sort of lesion. Sometimes they go away, so we have to scan them. And then esophageal atresia, you could see, but the one that gets picked the most is duodenal atresia, because there's something called the double bubble sign, which is they have too big. You have the stomach and the duodenum that are distended.
Wow.
And the ones that we always pick for sure is congenital diaphragmatic hernias, which are your diaphragm is missing, or abdominal wall defects, which we don't have to get into. But again, it's your intestines basically when the baby's being formed. For the baby to grow, the intestines are outside. Once the baby gets some size, they're supposed to come inside of the abdomen, and sometimes it doesn't happen. So those are the ones that usually get picked up in ultrasound.
Yeah. So I think that the first, as we talk about these conditions, I think the key is to get good prenatal care, that if there's a concern, deliver your baby in a facility where there's all the resources, not only the newborn ICU, the NICU, the neonatologist, and of course the pediatric surgeons. So as a baby obviously gets born, and I remember this also, a baby's the second topic I want to touch upon that you guys deal a lot with in babies and in kids is hernias. So let's talk about that. First, explain to the lay public, what is a hernia?
Well, a hernia overall is a space where a piece of inside the bowel can go through in the abdominal wall. The most common are inguinal hernias. So what happens is, in females or males, the testicles or will be the round ligament. It descends around the 8 months of the pregnancy into the scrotum or the labia. 10% of term babies and around 15 of preterms, that hole is just a hole, never closes. And then that's going to be a hernia. Either it's fluid, it's a hydrocele, a communicating hydrocele. If intestine gets in it or an ovary, then it's an inguinal hernia. It's just that.
So the baby can be born with a hernia.
Yeah. It's actually all of them are born with it. It never closes.
Okay. So they're born with a hernia. Now, when do you think about fixing those hernias on those babies that are born?
So an inguinal hernia, the risk is incarceration.
Right.
So once you get diagnosed, if you're diagnosed at birth, usually we fix them in the hospital.
Before you leave?
Before you leave, you're already there. You have an IV. Those are the ones that get, and usually most of the premature babies that are already in the hospitals, those are the ones that figure out they have it. So the recommendation, if you get diagnosed, is not emergent, but it's urgent. So you should do it around a month. If it's somebody that you're diagnosed in the clinic, you see them and you schedule them electively, but you want to do them as soon as you get diagnosed because of that risk. And it's not going to get, the important thing for people to know is that once you have a hernia, it's not
going to go away. Right. Yeah. No. And I know because I deal with it in the adult world. So what about, somebody who's listening and watching now, they have a child and maybe the child's 2, 4, 6, something like that. And what should they be looking for in their child, especially the moms that are bathing little kids and checking little kids? What should they be looking for to make sure their child does or doesn't have a hernia?
Basically, most hernias are what we call indirect. So there's a bulge in girls, either in the inguinal region, on the groin, or towards the testicle, especially when the kids are crying and the babies or they're playing, you will see a bulge. Older kids, there's something called a communicating hydrocele. Actually, my kid had it and I operated on him, where the hole is too small. Only fluid goes through it, just water. So those are tricky because when they wake up, they don't have anything. At the end of school, they come in and they have the testicle is full of fluid. And you're like, what's going on here? So those are harder to pick up, but anything on exertion. And again, it will be harder not to pick them up. Usually in babies, you'll see him crying. And it's something important. It has to be reproducible. You need to make sure that the baby keeps doing it. So again, when I go to see a baby, they're crying. If they're crying, nothing's coming out. I'm like, this is probably not a hernia. There's other things you can have. Just fluid that goes away. So it has to be something that comes and goes and you can see it.
All right. And we didn't touch upon the belly button. What about belly button hernias?
So belly button hernias, the reason they happen, so we talked about the intestines being formed outside and they have to come all the way inside. So I think we all have a tiny defect.
Yeah.
I mean, if you have stuff going through it, that's a hernia. So we don't do anything up to 4 or 5 years old. And then in Europe, sometimes they even wait longer. Why do we wait? Because they could close. And if they don't close, at least the ratio of the patient versus the defect is smaller, even if they don't close. You don't want to do
the patient gets bigger and the hernia doesn't get any bigger and it becomes relatively a smaller hernia.
And
right?
The muscle, because nowadays sometimes I will fix, if I have a baby with an inguinal hernia, we do it laparoscopically, we close, and I'm there, so I'm closing the belly button. and they will reopen. So the muscle is not ready. The tissues are not ready for a repair on a baby. So on those we wait, and if they make it to 4 or 5 that hasn't closed, then we repair them. But the risk of incarceration is minimum, and it's rare to see it. So those you can wait. Obviously, there's a lot of when the parents, when they're babies, you see this big hernia, and you tell them you just have to wait. I mean, the pediatrician might not even send you to a surgeon because we're not going to do anything. There's cases when you have a 1-year-old, 2-year-old, what we call a proboscis, a huge hernia, and the skin is stretching. Those kids we tend to fix earlier because you don't want this skin to be all stretched out, and then you have to do what we call an umbilicoplasty. It turns into a plastic surgery operation. We try to avoid that, but 90% of the patients, you wait till 4 or 5, hasn't, if he hasn't closed, then we do it.
So what I'm understanding is if you're a mom or a dad and you see some swelling in the groin of your child, you should see the pediatrician, and those patients should probably have their surgery done soon.
Yes.
If you see swelling in the belly button and the baby's less than 4, then probably not. But if it hasn't gone away and the kid is 6 years old, probably should have the belly button fixed. Yes. Okay. So now we're going to fix the hernia. So how are hernias fixed in these little kids? Whether it be, talk to me about newborns and talk to me about 6-year-olds. How are you guys fixing hernias?
So the original operation is an inguinal approach. We never, something important, especially because the parents, we don't never use mesh. We just do what we call a high ligation. You go in, and that little hole that we talked about that's open, we just close that. We just close in the peritoneum with the inner layer of the abdomen. That, is an operation that's been done for 100 years. A high ligation, you fix it, you take the hernia sac out, and you're done. Nowadays, some surgeons do it laparoscopically, and you put a camera in the belly button, and then you just close the hole, and it's basically scarless. You just have a little dot. Importantly, though, is that even if you do it open, and there may be the risk of what we call recurrence of the hernia coming back might be higher on the laparoscopic. People don't really know because it's kind of a new approach. You always want to, especially smaller babies, you want to look at the
other side.
So we said on girls, 50% of girls have a bilateral inguinal hernia, even though they're not symptomatic. So you want to look. Boys is less. So up to 2 years old, you always check on girls. And if you have a 5-year-old, probably you don't have a symptomatic hernia, you're not going to have it. So if you're doing it open, you can put the camera, because remember, this is communicating into the abdomen. So you can put a camera and look at the other side. Obviously, when I do laparoscopically, I'm looking at both sides and I fix them. But the operation is a high ligation, never mesh. And it's a dealer's choice if you want to do laparoscopically. Obviously, I like doing laparoscopically, so I'm going to tell you about that. But an open hernia repair is totally perfect. And that's how you fix it.
Yeah. So it's very interesting you say that, because obviously in adults, and the inguinal repair of a hernia is, really standard of care is mesh. But in kids, it's not. And I know my son had a hernia repair at the age of 6. And they never placed mesh in him, of course. And he's now 21 and he's done great. He's doing great.
It's funny because if you think about it, and I'm pretty sure you talked about this before, but what we call an interior hernia, it's the same hernia in an adult and a kid, and we fix them differently. I mean, obviously there's issues with muscles and stuff, but it's kind of, sometimes I talk to my adult friends and I'm like, how can you get away with not doing it? And sometimes I do adults because, I train in both, and I will do a high ligation and then the mesh, but I do a combination of the both procedures when I do missions and stuff, because I think it's like the best combination. I put mesh, but
I was actually talking about missions when we used to do a lot of surgery in Haiti, and 15 years ago in Haiti, and I remembered, the high ligation on the babies and operating on babies with inguinal hernias. So definitely knew that. So far we're here with Dr. Eddie Perez, a pediatric surgeon. We're talking about child and children and neonate surgery. We've already talked about atresia, which is where your intestinal tract is not connected. We've talked about hernias. And last but not least, we're going to talk about appendicitis. Okay. Appendicitis obviously can occur as a child. It can occur as adult, and so forth. But, obviously more common in the young people. And I always say, to the 70-year-old patient, when I see them with appendicitis and I'm operating on an elderly person with appendicitis, I tell them you must be young at heart, because an appendicitis is more common in children. So let's talk about what is the appendix and what is appendicitis.
So the appendix is, as I call it, appendix of, it's a little protuberance that's in connection with the cecum, which is the first part of the colon. And it's totally communication. There's been studies to try to figure out what the appendix does. I always tell people it's there to fit the surgeon, so we can send our kids to college. But there's some people have done studies on the sleep cycle, and so there might be some cells there. Who knows? But the truth is in communication with the cecum. Some people have longer appendixes or smaller, and the reason you get appendicitis is because that appendix gets blocked, either by a ball of what we call an appendiculate, a calcified ball of poop, or whichever it is. And once that communication is lost, then there's bacterial overgrowth, and you get inflammation, and then perforation, or whichever it is.
So how do I know if my kid has appendicitis? He's been for the last 3 weeks having stomach ache and vomiting, and does he have appendicitis? I mean, what are the usual things?
That's a hard one. So probably of 9 out of 10 kids that come in with belly pain, it's not appendicitis. There's a lot of viral stuff going on, gastroenteritis, and it can mimic appendicitis. What we call about differential diagnosis is things that you can have, and you have mesenteric adenitis, which your lymph nodes get enlarged and it hurts there, or in girls, it can be ovarian pathology. So if you have something going for 3 weeks, it's not going to be appendicitis. So it's usually what we call is a 1 to 2 day process. The book answer is you have somebody that presents with nausea and vomiting, the belly hurts centrally around the belly button, and then it moves to the right side. And the kid will really have pain. I mean, then they don't want to eat, and they're tender on that right side. By the time, usually most parents already go either to the pediatrician or the ER. When they're seeing, you start having pain, you give some pain medications, but then your kid, you're like, this is more than a regular
stomach ache,
and he's localizing. And then they go to the ER, and then we work it out. And I don't know if we're going to go into that, but
no, definitely. We're going to go into that. And so really, I think the take home message is if you notice that it's just not a couple hours, it continues more than a day or two, and they have pain that's going to the right side. So the appendix is on the right side. Remember that. And if they have pain, that's more on the right side. So now they go to the ER. And how do you guys decide if they have appendicitis?
So there's basically, you go first, the history. Again, if you tell me my kid has been having this for a week, you're like, I think, it should have been declared already. There was appendicitis. But you go by the history, and then you do your physical exam. And there's specific signs of appendicitis, what we call rebound, or like signs that you have peritonitis in that area, inflammation. Then you do labs, and if your white blood cell count is elevated, or CRP, a series of labs, you're like, there's an infection going on. With those signs, old school, you say, based on exam, this is appendicitis. Obviously, things have changed, and now we have imaging.
Everybody wants imaging. Everybody wants a CAT scan. Everybody wants an ultrasound. Okay. So do all the kids get all CAT scans and ultrasounds?
Well, they used to, and we've made an effort not to do CT scans on kids because there's a radiation component to it. So ultrasounds are, again, like we were talking prenatally, now ultrasounds are much better. And on the ultrasound, they can visualize the appendix, and they can tell you exactly the measurement and if it looks inflamed or not. The problem with ultrasound is actually sometimes it's so good that sometimes you overread it, and you might show inflammation of the appendix
when it's really not.
Well, because if you have gastroenteritis, I always tell the parents, your appendix is inflamed because it happens to be there next to the bowel that's inflamed, but it's not the source. So when you have appendices that are borderline, those are hard to diagnose. Sometimes they get admitted, and you don't give antibiotics. You watch them for a day, and most of the times they get better. If they don't, then you're being declared appendicitis, and you go to the OR. So uncomplicated kids that you're thinking the perforation and abscess, those are the guys that get scanned, or they cannot visualize the appendix. But we really are avoiding doing CT scans on this case.
So the kid goes to the ER. They find out that it's likely appendicitis. You guys do the ultrasound. It shows appendicitis. Okay. Now, obviously, everybody knows and everybody understands that appendicitis, you treat with surgery. But is there a treatment also of no surgery for appendicitis?
So yes, we always tell the story. You're in a cruise or the submarines, and if you had and this happened with diverticulitis, which is another type of disease that we started to figure out. We have to give antibiotics. We couldn't operate on them. And so there's two areas where you treat with antibiotics. If you have what we perforated appendicitis, bad appendicitis, the baby has an abscess, those babies, those kids, you want to treat with antibiotics first, or we call cool them enough. Because can I do the appendix? Yeah, I can go in, but the risk of complications are higher. When you go down there, I tell the family, I only want to take the appendix. I don't want to take anything else.
And you end up taking a lot more.
So those guys you want to watch, you put them on antibiotics, and then 8 weeks later, you take 6 weeks, you take them to the OR and do the appendix. I think in adults,
we do the same.
And in some, if you have an 80-year-old, you might say,
leave it on, right?
But now they're talking about treating appendicitis with antibiotics only. When you compare the groups, still the complication rate for antibiotics only is higher, because the complication rate for an appendectomy is pretty. So that's why it's been harder to take it. And my personal opinion is that a lot of when you look at these rules, you have to have an appendix that's small, no appendicolith. So to me, those might be just kids that have like a viral appendicitis or just gastroenteritis, and we're grouping them, you're giving them antibiotics and they're doing fine. So the question is, how we're seeing this group. So the recommendation still is an operation. But yeah, if you are in the middle of nowhere and you need antibiotics, or you decide, you know what, I'm going to try, you can give antibiotics. It might not work, but you can get away with not doing it. The problem is the recurrence rate. If you had appendicitis already, the chances that you're going to get it down the road
is higher.
So you might be just
delaying it
for the next presentation.
I think that's one of the hardest conversations that I have with patients, is that they're there in the ER, they have appendicitis, but they have a perforated appendicitis with a large abscess, and you tell them, we're not going to operate on you now. But what do you mean? I have a perforation and everything else. And so understand that there are time periods where the surgeon will recommend against surgery at this time, just antibiotics, and let it all cool down. And we deal with that in the adults. So appendectomy surgery, another beautiful operation, simple, laparoscopic. How is it done?
Simple. We basically used to do laparoscopically with 3 trocars. Now we're doing what we call single site, and we do it because in a kid, the distance of the appendix to the belly button is smaller. Yeah. So we have a camera. You can do it with 2 instruments in the belly button, or you have a camera that we call an operative scope, and you put the camera and you can put 1 instrument in it. We bring it out. And sometimes I can add other instruments to the belly button, pull the appendix out to the belly button, and then you do it. It's basically totally scarless. There's no scars.
Wow.
If it's perforators, then we just do it laparoscopically. They do fine. And most of the kids can go home the same day. If they're just what we call uncomplicated appendicitis, no fever, no. And if you have a perforated appendicitis, which is like 20% of the kids, or gangrenous, or they have fevers, they stay on antibiotics. But most, you'll recover and they do fine.
Wow. Well, we've learned definitely about a few topics that you deal with. And I remember a pediatric surgeon deals with everything, more than me. As a general surgeon, I am, and a bariatric surgeon. I don't deal with the lungs and the esophagus, but he deals with all that as a pediatric surgeon. So we've heard about a couple topics. We've tried to give you some warning signs, getting good prenatal care, getting good ultrasounds, and being at the right facility if you have a baby in utero that may need some specialized care. And then we've kind of educated you about hernias and appendicitis for your children and your grandchildren out there. So I want to thank Eddie for coming.
Oh, thank you for having me.
Thank you for coming, and thank you for educating our community. And once again, Dr. Anthony Gonzalez, reminding you always to be healthy and be safe out there. Dr. Anthony Gonzalez here, signing off from Miami Community Health. You guys have a great day.